Thanks very much.
Chair, ladies and gentlemen of the committee, on behalf of the Irish College of General Practitioners, many thanks indeed for inviting us to make a submission and to assist in the really difficult and important and complex task that the committee has embarked on. At the outset, on behalf of the Irish College of General Practitioners, we wish you the very best in successfully completing your job. My name is Dr. Brendan O'Shea.
And Dr. Karena Hanley.
We have been requested to present the Irish general practice perspective on crisis pregnancy, focusing on the health of the woman, with no distinction being drawn between physical and mental health in the context of the 8th Amendment of the Irish Constitution. GPs who are family doctors are familiar with the reproductive healthcare challenges facing Irish women. Firstly, Irish GPs provide antenatal care to Irish women, and for the majority of pregnant women, antenatal care and support before 20 weeks gestation is provided by GPs alone. After this date, GPs provide shared antenatal care with hospital colleagues in obstetrics and midwifery. Secondly, when a pregnancy is unwanted, Irish GPs support and provide evidence-based care for women through this difficult experience, which will be articulated throughout this submission. Thirdly, Irish GPs provide high-quality contraception health care to Irish men and women. Thus, the Irish College of General Practitioners is well placed to understand the concerns and fears facing Irish women regarding reproductive health care. The ICGP has been asked by this committee to focus on the health of the woman, with no distinction being drawn between the physical and mental health in the context of the 8th Amendment of the Constitution. The World Health Organization definition of health since 1948 states that health is a state of complete physical, mental and social well-being, and not merely the absence of disease or infirmity. Evidence-based management of crisis pregnancy, with a focus on the effects on the health of the woman, is included in this evidence-based submission.
Crisis pregnancy is a pregnancy which is neither planned nor desired by the woman concerned, and this can affect women of any reproductive age, any social group and in any area of the country. It is common. Up to 13% of pregnancies can be considered to be crisis pregnancies, and most of these do result in parenthood. About 14% end in miscarriage, about 21% end with abortion, and about 1% lead on to adoption. It is still the case that over 3,000 women travel from this country a year to obtain abortion elsewhere. But a rising concern is the rising number, more than 1,000 each year, who obtain abortifacient pills online and administer these themselves without medical supervision. How do we prevent crisis pregnancy? Effective contraception is key, and GPs try to be proactive in providing available contraception to all women who are sexually active. Our colleagues in the HSE Sexual Health and Crisis Pregnancy Programme support a wide range of educational programmes, research, counselling and medical services, and also the Irish Family Planning Association provides excellent contraceptive care. But despite all the efforts of government, education and services, crisis pregnancy cannot always be prevented, and most GPs witness and take care of crisis pregnancy quite commonly. We know that abortion rates are lowest in health systems where contraceptive services are most readily available, and as you heard yesterday, there are still barriers to contraceptive services, particularly cost, and also concern regarding confidentiality, which is actually misplaced, but it remains a concern, particularly of younger women. It is true that the 8th Amendment does not impact on contraception and emergency contraception care for Irish women.
We move on to the management of crisis pregnancy, particularly as it's experienced by members of the Irish College and general practitioners throughout the country. To help outline the typical crisis pregnancy scenario, we outline a typical anonymised vignette. Background, Sandra is a 38-year-old woman. She presents to her general practitioner. She has 3 children, but separated from her husband 3 weeks previously, as he had become increasingly abusive towards her and her children. The GP has become increasingly concerned about Sandra's isolation and lack of supports. Sandra comes to see her GP and states that she missed her period 2 weeks previously. She thinks she may be pregnant, but she hasn't done a pregnancy test herself. She looks concerned and is anxious. Before the GP performs a pregnancy test, they explore Sandra's feelings and ask if she would be happy if she found out that she was pregnant. Sandra bursts into tears. The GP listens to her many concerns and explains that no matter what happens, the practice will be there to support Sandra in the consultation and beyond. The GP proceeds to check a urine sample and confirms that she is in fact pregnant. Sandra looks despondent and says she doesn't want to be pregnant. Every crisis pregnancy is different. Reasons why a pregnancy is unwanted are personal and unique to each individual and circumstances and their family. However, the approach taken by the doctor to managing crisis pregnancy is the same. Firstly, there's confirmation of the pregnancy. As the vignette outlines, the GP cannot assume that all pregnancies are always wanted, but GPs are well placed to sensitively inquire about the woman's feelings and confirm the pregnancy. Secondly, we proceed to non-directive counselling and discussion of options. The next step in management is to support the woman to reach the best decision for her, providing a safe, reflective space for her to do so. The main goals involved include maintaining trust, helping the woman formulate a clear definition of the problems, and establishing the goals of management so that the crisis can be resolved. And this involves non-directive, non-judgmental, compassionate, empathetic listening, sometimes over 2 or more consultations and over weeks. There is a legal obligation on those providing pregnancy counselling in Ireland, including general practitioners, to discuss all options in a non-directive manner where a woman wants information on abortion. Thirdly, beyond this, there are 3 options available to the woman: continuing with the pregnancy, abortion and adoption, although the latter is relatively rarely chosen. A doctor has an ethical obligation not to allow their personal moral standards to influence treatment of patients. Where a doctor has a conscientious objection to a course of action, they must explain this to the patient and provide the names of other doctors available in a timely manner to the patient. Effective communication in a crisis situation demands time, considerable patience and careful thought. The GP must enable the woman to reach an informed decision, to minimise emotional disturbance, whatever decision is made, and to lessen the risk of further unwanted pregnancy. In general practice, we hope and we believe women find space, are listened to, are able to share, explore and address their concerns in a familiar setting with a physician who is very familiar to them in most cases. Supporting this personalised care is a core value of the ICGP, so that these consultations, and indeed any other consultations involving the woman and the process of decision-making, are all undertaken in a non-directional and supportive process. The role of the GP and the practice nurse is chiefly concerned with the provision of support, information and clear commitment to follow-up care with the practice. Sometimes specialist counselling is required. For example, if a woman is younger or has poorer support structures or has an active, significant mental illness, they may benefit from specialist counselling services. And in this case, Irish GPs may recommend a specialist accredited counselling service which offers accurate information. These services are funded by the HSE Sexual Health and Crisis Pregnancy Programme, and locations and descriptions are found in Positive Options. Continuing the pregnancy. If a woman chooses to continue her pregnancy, the GP will continue to provide compassionate antenatal care to the woman, ensuring adequate supports are present and addressing the important issue of postpartum contraception. Choosing abortion. In the clinical vignette we've described, Sandra chooses to travel to the UK for an abortion. For a woman who chooses an abortion, GPs cannot actually refer or make an appointment on behalf of the woman at a clinic in the UK. We may provide a copy of their medical records to the patient. GPs would also encourage women to return to the practice after having an abortion if they have any concerns. GPs would also discuss post-abortion contraception. Irish GPs may need to consider a dating ultrasound if the dates around the pregnancy are uncertain. As indicated, any GP who has a conscientious objection must refer the woman in a timely manner to another colleague. We state that abortion is relatively a very safe medical procedure. The ICGP understands that increasing proportions of women will purchase online hormonal abortifacient medications. In these instances, it may or may not become known to their GP in subsequent consultations. There is clearly increased use of illegal abortifacients, both from anecdotal evidence from GPs and from objective measures such as custom seizures, and a recent paper which suggests that over 5,000 women requested abortion pills in this way between January 2010 and December 2015. The trend is increasing significantly and rapidly.
I'm going to talk about the impact on the health of the woman, and I'm going to start with travel. Reflecting on the vignette, you can understand the psychological cost to that woman, the stress, the loneliness, and just the psychological burden of travelling to procure an abortion. But there's also a physical risk. As women who, as they travel, they do not have access to the post-abortion services that are available in the country in which it is performed, and this is a risk to them. There's also logistical difficulties and financial costs. And also, crisis pregnancy can have a profound effect on the woman's partner and wider family, but for this presentation we have focused on the woman only. The logistics of travel also mean that women travelling from this country tend to have later abortions and to have a higher proportion of surgical interventions. There are also the women who cannot travel, those who are disabled, those without the financial means, and asylum seekers cannot leave this country for abortion. We'd like to bring to your attention the harm that can also be done by inaccurate information from unlicensed, unaccredited counselling agents who sometimes give distressing and incorrect information. And now I'm going to talk about the Protection of Life During Pregnancy Act. This allows for lawful abortion where there's a really unsubstantial risk to the life of the mother. And most of the 25 terminations that are conducted under this are performed by our obstetric colleagues, and GPs are not involved in this, but we are involved where the risk to life is the risk of suicide. The clinical pathway in this context requires referral from the GP to local general psychiatry services, and 2 psychiatrists and 1 obstetrician then need to agree that an abortion is lawful under that act. Very few cases have been performed under this arrangement, and the experience of Miss Y needs to be considered. Certainly this arrangement tends to lead to delays in accessing termination of the pregnancy, and if the second psychiatrist is outside the location, this adds to the difficulty. Criminalisation really needs to be considered, and this is to do with the increasing numbers of women who procure abortion pills online. They may be criminalised with the potential of a 14-year prison sentence, and this may prevent them from reporting to Irish doctors, which could seriously impact on their health.
Summarising and concluding, the ICGP is thankful that the Oireachtas Committee on the 8th Amendment invites our input. Abortion is a divisive, difficult and polarising topic. Indeed, Irish general practitioners have debated this theme internally within college, and similarly to the broader population, we have witnessed conflicting opinions, concerns and beliefs among our own group. The constitutional criminalisation of abortion in Ireland has made this a more difficult issue to discuss in public. It has also made it a significantly more difficult issue when attempting to provide care in the care setting. However, crisis pregnancy is a large-scale reality facing Irish women at present. Many Irish women choose to access abortion services, which we must deal with more effectively as a society. The 8th Amendment clearly raises difficult ethical and moral issues for the public and healthcare providers, but we hope that the ICGP has informed on how crisis pregnancy can impact the health of the woman and how GPs presently care for such women. Today, we outlined the impact on the health of Irish women as requested by the committee. Today, we will not recommend solutions, for that is for this committee to decide. Thank you for listening.
Thank you.